great. It's always handy to have a technician on board. So I'm going to talk to you about sleep and pain, but because of the walk that we had from the pain emotion group to here, and Neil was telling me about his impression of Coventry, if you know where it is. So I thought that it is really important that I bring Coventry to you because you haven't had a chance to visit. I have to say that my original assessment of Coventry was similar to Neil's assessment, but I was changed. How many of you have been to Coventry before? Aha, only just you. Okay. So it's actually in the middle of England. It is like the middle point of England that is so much debate that people are trying to compete for the title of being the center of England by marking different trees in the local area. I have come across 2 trees that claim to be the center point of England, so I don't know which one is true. But if you were to take the Eurostar to London, it would be about an hour away from London, so it's relatively easy. If you're going to visit Oxford or the Bath Research Centre for pain, they are only about an hour away, so it's like you can see the triangles there. So we are in the middle of England. So it's actually slightly different from the Coventry that Neil used to know. It has been quite an interesting area where the university has transformed the campus into lots of different nice buildings. But actually, the campus is rather green, and if you do walk on the campus, it's quite large, and so you can spend some nice time there. But some of the things that you may not know about Coventry and Warwick is that if you walk around, you can still see medieval castle. So in the town, nearby town, Warwick, about 20 minutes drive, you can still see that medieval castle called Warwick Castle. And people are still doing jousting there. It is a highly recommended show, and if you do go there and visit me, I will be very happy to take you to the Warwick Castle. It's very interesting. And if you want to stroll around in the middle of England, you'll come across the Cotswold, where the rich people, I think maybe Ellen DeGeneres has recently moved to Cotswold because of whatever is happening in the US. So nearby, there is a Stratford-upon-Avon. Some of you may know this guy called Shakespeare's. He was born there, and there's a nice area there where you can visit his birthplace. And on campus, we have a very big presence of JLL, which is this Jaguar Land Rover. So I haven't come across James Bond on campus just yet, but you do manage to see some of the prototypes and some of the cars on campus. At one point, they even have a Formula 1 race car somewhere in one of the office buildings. So it's kind of fun. And occasionally, you do see the prototypes in camouflage on campus. But we do have a really big prototype building in the middle of the campus for the Jaguar Land Rover. So Warwick is a relatively young university. It's only about 60 years old. So we are celebrating its 60th birthday this year. We are known for quite a few things, but one of the things that really rock the world is these naked rowers who have been producing naked calendars for charity. So I thought that I would bring this sensation to you. So Neil, has it changed your impression of Coventry? Very much. Okay, that's great. So that will be my start. So in the middle of all this, I've got a research lab in the psychology building. I call it the sleep and pain lab, just trying to join up 2 research interests of mine. So these are photos taken a couple years ago, but the good news is we are moving laboratory, so we're going to double the capacity. We'll have 2 bedrooms, we'll have got some new equipment so that we can invite people to come in and stay overnight for some pain and sleep research. So exciting stuff coming ahead. So in this talk, coming back to research, I just have 4 things to talk to you about. Like the title, I just want to start with sleep. People always have sleep as an afterthought, don't they? Even if you talk to a professional, knowing the importance of sleep, sleep is somehow an afterthought. But it is so different when you do talk to patients. When you talk to them, they will tell you that sleep is absolutely one of the priority. And I would like to start with that hypothesis, or maybe even proposal, that you and I will share that understanding that improving sleep should be a treatment priority for chronic pain patients. And then next, I'm going to go through some of the existing treatment options. It's not going to be a long section because there aren't a lot. And then moving on, I would like to tell you a little bit about cognitive behavioral therapy for insomnia, even though you probably are the expert of that already. Just so if there are audience joining us online and they're not aware of what is CBTI, that would be the opportunity to give an introduction. And then finally, I would like to finish my talk by highlighting some of the implementation challenges that we have had in the UK and possibly globally, or maybe it is a problem shared in Belgium as well. So I'll start with improving sleep as a priority. To begin with, chronic pain, just want to make sure that we are talking about the same condition because they have been changing definitions recently. I'm referring to pain that persists and recur for more than 3 months. So it is a slightly more generous definition. But it could be referring to multiple pain conditions. That could be musculoskeletal, the condition that you may care quite a lot here in VUB, but it could also be inflammatory, neuropathic, nociplastic, and a lot of the time clinically when you see patients, it's a mix of different picture. So recently in the ICD-11, the definition is more concerned about whether or not it is primary pain and secondary pain, but I think we are referring to both, like when they have been here for more than 3 months, we can consider that as pain that sustains itself and has different mechanisms that keep it going. And as you can see from the body pain map, pain happens everywhere. Even if it is only starting with just one location, it can spread, it can travel. Although most commonly in clinic, you do see a lot of patients complaining about back pain, knee pain, head pain, followed by leg, joint, etc., etc. And that is data coming from the 2016 big survey by Biography. Looking at that survey, chronic pain matters because it has a very high prevalence. I imagine in every grant application we'll be talking about the prevalence of chronic pain, although it is actually really hard to pinpoint how many people in our society have chronic pain. But according to this European plus Israel study, they said that the average prevalence is about 19%. Unlike the UK's performance in Eurovision, we did quite well in terms of prevalence, not too high, rank bottom third, about 8 million people in the UK with chronic pain. If we use that stringent criteria of 6 months and then having pain in the last month and several times a week with pain of certain severity. And then if we look further down the list, and I saw Belgium here, so probably you would be very familiar with this figure. I think it's about 2.8 million in Belgium with, roughly, if you translate that percentage of 23%, so slightly higher prevalence. It also matters because chronic pain makes living tough. It is not easy at all to live with pain 24/7. And in fact, if you look into the primary care data, pain is one of the most common reasons why patients seek medical treatment, and it is a major source of suffering. And so you may be very familiar with the onion model by John Loser. So you can see that nociception can take another level up to pain, and then it is the suffering that determines pain behavior. Just want to take a detour from here when we're talking about suffering. I think I was talking to one of the students here in this group talking about for cancer patients, they have that sense of perceived injustice. And I think we are also touching on the concept of suffering across different conditions. In fact, when we talk to a lot of chronic pain patients about their experience living with chronic pain, we heard a lot about defeat of the mind when people are talking about how pain has taken over, that you can't really cope with it no matter what you try, what you do. And then everything else that they do in their life feels like they have been beaten by the pain and there's nothing else that they could do to fight against it. And so all of that results in them thinking that they are being belittled by the pain, and it feels less like a human being to a lot of chronic pain sufferer. And so we call this sort of concept called mental defeat. And because of that suffering, we have been doing quite a lot of research about that. And, I'm sort of fascinated by some of the extreme cases, how this sort of sense of suffering could drive people to do something extreme, like this case of someone called Luigi Maggioni in the US. They gunned down the the healthcare insurance CEO, and there has been story about him suffering from back pain. And this guy, as reported in the news in the UK, developing his own guillotine in the backyard, trying to chop off his own arm so that he's not feeling the neuropathic pain, because he has been going everywhere to seek treatment, but nothing helped. Or, a lot of the time you come across stories, tragic story about people choosing to end their own life, to end the suffering. And so for me, having talked to a lot of patients, seeing lots of cases, high level of distress and disability, I'm very intrigued by that sense of defeat, that sense of suffering. So if you're interested in that line of research, happy to talk to you tomorrow if you're around or if you have time, because I've been looking into pain and suicidality for some time, starting with a pretty old review paper, but it seems to be quite popular among clinicians and researchers. And then from the clinical interview, we developed the concept of mental defeat. And then we did some more quantitative study trying to understand the association between mental defeat and people's outcome. Resulted in, a grant and then more funding to make this resource available to clinician and researcher if they're not doing commercial activities. So we've just set up a whole web page where people can download the scale to do this. I think it is very promising because it seems to be one of the best predictor of suicidality in the chronic pain population. And we have done quite a few studies trying to evaluate that in both UK population, in different population, using different scales as well too. So the scale has been translated into Japanese, Spanish, and Chinese, and so we are investigating it further. But in the two recent papers that we have published, we saw that prospectively, mental defeat did better than depression and perceived stress in terms of suicidality. So if you're interested in that aspect of chronic pain, happy to talk about it later on. But coming back to the other problem about chronic pain, because living with it is not easy, because it doesn't restrict its impact to the day, limiting what you do. If you look at this surveys data, obviously exercise, lifting, doing the walking is hard for patients, but you can see that sleeping is also affected a lot by chronic pain, with lots of people talking about how pain makes it unlikely for them to sleep well. So this has been my obsession for some years. If you look at the scale of the issues using validated questionnaire like the Insomnia Severity Index, you will notice that if you are taking a sample from the clinic, just look at the clinical level of insomnia, you can see somewhere between 53% to 79% of the patients that we see coming through the door of the clinic would report clinical level of insomnia that warrant treatment. And that is absolutely important. And so as a clinician, you can't really just overlook a key issue by not treating them and say, well, because we are a pain clinic, we only treat your pain. And so I thought that, we can be a little bit more flexible and see this problem more squarely. And if you were to look into, what about the subclinical level? That can also cause distress and problem, although you may not see that as the clinical level of insomnia. And that figure is also about like 72% if you look at the meta-analysis published by Sun et al. In terms of the clinical characteristics, you probably know very well as well that for those people coming with chronic pain, if they do present with insomnia at the same time, they tend to have higher level of pain, more disease activity. If they have a conditions that counts disease activity, they would have higher level of fatigue, higher level of disability, worse mood. And if you do put them through treatment, they are the people more likely to have lower treatment gain compared to people without insomnia at all. And so this is not just only a clinician bias, because if you run all the medical records through, like the last point here, when you ask AI, AI, the robot, would also tell you that those are the patients with the most difficult presentation, just by running through the details on the medical record. And so you can use insomnia as a risk factor or as a marker of those people who are less likely to benefit from treatment and those people who are on the higher end of the distress and disability spectrum. You may recognize this guy. He has looked into the data. Thomas has helpfully looked into the data to see if insomnia, being such a marker, would help determine people's quality of life. And we used the EQ5D5L data of the Within study to see prospectively if insomnia can help predict people's quality of life. You may thought that it is very intuitive, but it hasn't really been done before. And so we managed to find 6 different significant predictor of quality of life in chronic pain patients. But you will probably remember that for the EQ5D5L, it has pain and it has mood in it, right? So when we take those into account, only employment and insomnia severity are non-overlapping predictor. So it says something about insomnia as something that potentially could be a target for treatment. The trouble is, when you are a clinician, you probably will need to make decision what to treat first, right? You have to, consider your time, consider your resources, consider your skills, consider the patient's priority. The trouble is, if we don't prioritize insomnia, it will stay. If you look at some of the longitudinal studies tracking what would happen naturally if you don't offer people specific treatment for their sleep, what we found is that it tends to say, at least for the majority of the people, 70% of the people will report no change in the insomnia status in a year, although there will be some movement for people with insomnia to become, better sleeper again, or for better sleeper to become insomniac later on. But we know that it is quite stubborn. And the other thing is, if we don't treat insomnia and let it develop, let it brew, what would happen is that it will tend to make pain worse because of its interaction with the pain system. And in fact, Neil would probably know quite well that, again, sorry, picking on you, that if we don't treat it, it will react on the pain symptoms. And in fact, we have got to the stage where we know from the literature that the association from sleep to pain is much stronger than from pain to sleep. So quite a few studies, both the conventional longitudinal studies have identified a strong link between sleep and subsequent pain incidents. So there's a temporal separation there with sleep predicting subsequent pain onset. So you can see a number of different diseases, including musculoskeletal condition incidents, where we can split it into short and long term, thankful to the hard work of your group in publishing that recent meta-analysis. We now know that the short-term risks of having MSK condition would be like 64% higher for those people with sleep problem earlier. And also for micro-longitudinal study, we understand that even at a very close proximity, day-to-day association, sleep will predict next day's pain. So Saucier's meta-analysis has demonstrated this point really beautifully. So if you haven't read that paper already, do go back to it, because it really helps to gather the latest of the literature on this particular issue. So we have a relatively well-established consensus that sleep has a strong impact on subsequent pain, both in the short term as well as the long term. A lot of people have been, looking into the pathway, although I don't think we have a very clear idea what is actually causing the association between the two. There has been a lot of hypotheses whether or not it is cognitive, behavioral, physiological, neurological, or multiple at the same time. Like this group in Harvard, so they have been looking into the role of inflammation, and I think Hu Yang might be interested in the role of inflammation in fibromyalgia. And so they have been investigating the inflammatory marker using experimental studies where they allow people to have the normal sleep or they sleep deprive them so that they've only got 4 hours of sleep for a night and consecutively doing so for 10 days. And when they did that and then subsequently measured their self-reported pain rating, both in terms of bodily discomfort or tiredness and fatigue, and then they also take blood in order to check the inflammatory marker. So interestingly, of all the different inflammatory markers, they've only found a significant difference between the two conditions for IL-6, but not anything else. When they did the correlation, they did find a strong correlation between the self-reported pain rating and discomfort rating with IL-6. Potentially, some of the inflammatory markers is doing the job. Although this is done with healthy people and then being introduced with sleep deprivation. So maybe the result may not be generalizable to the pain population. So something that needs to be investigated. And there is actually another study recently published using the UK Biobank data. They have looked into the mediation role of CRP, and they found only a very small effect for CRP mediating the effect from sleep to pain. So probably is somewhere there in terms of the inflammatory pathway, but it would be very hard to detect. There has been also researchers really interested in, the mechanical aspect, the pain sensitivity aspect, using lots of different testing in the lab, again using healthy participants, and with the introduction of sleep restriction or sleep fragmentation to see what would be the effect if sleep is not there. So they found a spontaneous increase in pain report. They also found a lowering of pain threshold or pain tolerance. And if you do pain conditioned responses, they have a poorer DNIC response, and also they have higher temporal summation. So there are data there, although I will have to say that they are relatively inconsistent, and depending on the modality and the combination of the different testing procedure, you may get very different results. Although generally speaking, we can say with some confidence that sleep fragmentation and sleep restriction tend to increase the level of pain sensitivity. And that is actually working really nice with this fMRI experiment, a very simplistic design but very clean. When they compare sleep-rested individual with sleep-deprived individual, next day pain assessment and fMRI, I think it's resting state fMRI. With a very small sample, they managed to find out that for the sleep-deprived group, they have a lower level of pain threshold, as you might expect. But interestingly, for the resting state functional MRI scan, they found out that there is increased activation in the somatosensory area of the cortex. However, for those regions that matter for pain regulations, like the nucleus accumbens and the thalamus and the insula, they seem to have a deactivation compared to the normal sleeping group. So it seems to work quite nicely with the experimental data suggesting the same thing. Although, sometimes, interpreting the fMRI results could be tricky, and so I will take it with a pinch of salt in terms of understanding the mechanism. For psychologists, we also have a role to try to understand, what's going on in terms of the psychological mechanism. So together with Dan Wellbeing, we have actually done a meta-analysis looking into all the mediation analysis that has a formal analysis procedure and see what they found. So we split the systematic review into two halves. So looking at the mediator that mediate the association from pain intensity to impaired sleep. So what you can see is that mood, negative mood, and depression symptoms seems to be the mediator of this association. So this is mainly pain making people grumpy or more depressed and then affecting the sleep. So it has something to do with emotion regulation. There are actually more mediators being uncovered by research compared to from pain to sleep. So we have more mediator of the association from sleep to pain intensity in comparison, although they are not necessarily mutually exclusive. So you can see that there is still negative mood there, depression and anxiety symptoms, increased attention to pain helplessness, but there is slightly stronger evidence for the activation of the HPA axis and also a higher level of fatigue. These are the things seems to be regulating the relationship from impaired sleep to pain. I have to say that although it is a systematic analysis of what we have in the literature, it probably is not a comprehensive picture. And I think probably researcher hasn't really have a theoretic model to identify what is going on. So it may still be a very biased picture, if I may say, but at least it helps to highlight what might be some of the plausible mechanisms governing the association here. So I guess, the search of the most relevant mechanism is still ongoing, and I think a lot of research is needed to pin it down. I think particularly a theoretical paper perhaps is needed to identify all those pathways, because if we don't treat insomnia, there will be long-term consequences. Like this one, a meta-analysis by Elizabeth Hertenstein. She's currently in Geneva. She has identified that if we don't treat insomnia, there will be the consequences of poorer mental health. In terms of the risks, the people will have 3 times more likely the risks to develop anxiety, depression, and some other psychiatric disorders if we just leave it untreated. So that's the reason
because of the pain.
I thought that it is really important to prioritize sleep. But if you still don't believe me, all this data being thrown at you, sometimes it takes some time to digest. But I thought that if you listen to our PPI, this is Anne Livingstone. She has been advising on our project. We have been picking on her brain because she represents a charity in the UK called Pain Concern. And so we have been asking them for advice. What do you think would be really important for patients like yourself suffering from chronic pain? And what do you think would be helpful for you? And she has fibromyalgia, but she also has osteoarthritis and some other back pain, etc. So a mixture of different things. So hopefully the sound is loud enough to hear it. Let's see.
Because of the pain and the discomfort I have, and I've never been a good sleeper, I think the whole thing just blew up into one unbelievable thing of, I don't know, what do you call that? That puff of insomnia. And I honestly believe that if my sleep had been addressed much, much earlier on in my journey towards managing my pain, the quality of my life would have been improved.
Yeah. So you see, for her, we have been talking about chronic pain treatment, but then she managed to come back and highlight to me that I wanted to have insomnia much, much earlier. And so it's a timing issue, because I think a lot of the time when people are thinking about sleep treatment in the chronic pain context, they tend to put it towards the end. But she is saying that we should have it earlier. So that is something to take note of. And in fact, when we looked through the literature, we did a recent qualitative meta-synthesis. Poor sleep was, described by patients as one of the worst symptoms that they have for their fibromyalgia. So hopefully you're convinced that, sleep is an important treatment priority. So if that is the case, what do we have for treatment options? And that is a valid reason to investigate. So recently, together with researcher from the University of Aberdeen, Nottingham, Michigan, and so on, we have conducted one of the largest systematic review of the existing treatment trials on fibromyalgia. Whether or not they are designed to target sleep, they are included as long as they've got a sleep outcome. So we managed to find a 90 randomized control trial for the analysis, and that includes 45 different treatment categories, including non-pharmacological and pharmacological treatments. And so for the Bayesian network analysis, we've managed to include data from 65 different studies with 35 different treatment categories. So you can see that we can compare the different treatment category with placebo or shame or usual care on a number of validated sleep measure in the fibromyalgia population at the end of the treatment phase. So the thing is, like, despite the fact that we made an effort to include everything, first of all, we didn't manage to identify any treatment trial for children and adolescents with a sleep outcome. So first of all, that is a neglected area. If you are working with this population, that may be something for you to think, oh, I can potentially contribute. There's not much for children and adolescents. The second thing is, for the quality of the trials being included, they are overall of high risk. So I would say that the quality of the literature is not that high. So with all these limitations in mind, what we found is that we currently only have evidence with certainty that land-based aerobic and flexibility exercise, so that may be something relevant to physio, land-based aerobic and flexibility exercise help with sleep, and also aquatic aerobic exercise. We do have some evidence with certainty that they would help with sleep, and possibly because there are more trials out there with large enough samples. But for a large number of things, including strengthening exercise, psychological therapy or behavior therapy with sleep elements, electrotherapy, weight loss, etc., and antidepressant like amitriptyline. Lots of patients will take amitriptyline. They are only intervention with some indication of positive effect, but we don't have certainty for those evidence. And then if you see on the right-hand side, that box there were lots of very popular treatment, right? Lots of drugs that people are commonly prescribed, but they are actually treatment with no effect whatsoever for fibromyalgia patients. So that is shocking in some way. If you have an eagle eye, you will also notice that one particular medication is not on the right-hand side for some reason, and they're opioid. And for some reason, they are not included in this trial. But we actually did another analysis before that looked at the opioid therapy's effect on sleep quality in chronic pain patients. And again, this set of literature is plagued by poor quality. But I think the other thing that is even more important is that there is a lot of potential conflict of interest that are not being reported. So you have to look really carefully to identify the association between the company that provide the drug for the treatment trial. But anyway, for the studies that we managed to include, they still have quite a large number of participants, like almost 4,000 patients, included in those trials testing oxycodone, morphine, tramadol, and hydromorphone, etc. Interestingly, if you read into the data of these trials, what you will find is that there was a significant and small positive effect on self-reported sleep quality for chronic pain patients if you use opioid therapy with them to help with the symptoms, including sleep. People did report that they are feeling calmer with fewer awakenings, etc., etc. However, and that is a big however, you really need to look into the surrounding of the reporting to identify that actually there are a lot of other problems that are not being highlighted in the headline findings. For example, the attrition throughout the whole RCT procedure. Lots of people are treated because they have severe sleep apnea during the titration period or the screening period. So quite a few people, like 20% is already gone because of sleep apnea, undesirable side effects, etc., etc. And because of opioids' pharmacological property, it depresses your airway, so it makes sleep apnea even more severe. And there are some other issues with the use of opioids as well too, like daytime sleepiness, it changes your REM sleep architecture, etc., etc. And so there is a big question mark there because of a consideration of attrition and unintended or undesirable side effects. And there is also severe AE in some of the trial, people being very unresponsive. and that was related to the drug. And so be very, very careful with the use of opioid therapy in a clinical setting. So yes, so although for the self-reported data, there seems to be some positive effect, the use of opioid for treating people with pain, with insomnia, perhaps is not necessarily the best option. So what about cognitive behavior therapy? I think there is a case for using that simply because if you look into the patterns of sleep disturbances between patients with the so-called primary insomnia and patients with pain-related insomnia, you don't really see a lot of differences in terms of the macro architecture, and you will be seeing that frequent awakening, stage shifts between different stages of sleep throughout the night will be higher. People will have more shallowest stages of sleep like M1 and 2, and a decrease in the percentage of deeper stages of sleep, which is the stage of sleep that people would associate with restfulness and restoration. And so it's mainly sleep fragmentation that people care about. Neuroscientists and a lot of experimental researchers have been trying to find that signature, neural signature of sleep disturbances in chronic pain patients. But I have to say that there are candidates out there, but none of them has the sort of specificity for the chronic pain population, and none of them has been recognized as a neuromarker whatsoever. And so if we hypothesize that perhaps they're comparable, we can treat with the macro architecture. Look at what people have been doing for the primary insomnia group. Back in 2010, if you look into the British Association for Psychopharmacology consensus statement, they have been advocating for the use of CBTI already back in those days when the evidence for CBTI wasn't out there. They are already saying that CBTI should be offered as a first-line treatment and made more available in other settings. And then 6 years later, the American College of Physicians have exactly the same recommendation, CBTI as the initial treatment for chronic insomnia disorder. And it is a strong recommendation based on moderate quality evidence. And then in Australia, they have also got a consensus statement recommending CBTI. And then in 2017, the European guideline, that is the first version of it, came out. And this time it is based on strong evidence, high quality evidence, that CBTI should be recommended as the first-line treatment for chronic pain, chronic insomnia in adults of any age. And pharmacological intervention can be offered if CBTI is not sufficiently effective or not available. And this guideline has actually been recently updated in 2023. And this time, what is relevant to us is that they said it should be offered to adults of any age, including patients with comorbidity. So it's not just only the primary insomnia group now, it's also for patients with comorbidity, and it can be done either digitally or in person. So the level of evidence is high. Level A, 1A. So what do I mean by high level of evidence? Because if you look into the availability of meta-analysis, there are 25 for the use of CBTI for people with insomnia without comorbidities. And they are all showing large effects on insomnia severity post-treatment, small to medium effect at up to 1 year follow-up. And if you are more medically minded, the number needed to treat is 3, which is as good as paracetamol. And that is really, really good as an NNT for the medics. And in terms of remission rate is 6 out of 10 in 6 months to a year. So that is not too bad, although it's still not perfect. For the use of CBTI for people with insomnia and comorbidities, we have already got 15 different meta-analyses showing similar effect, medium to large effects on insomnia, but importantly, there are also positive effects on comorbidity. And so that is really encouraging. And I'm glad that my lab is one of the groups that have contributed to it, particularly for chronic pain population. So a slightly older meta-analysis trying to look at the effects of CBTI on pain outcomes, as well as some other related outcome like fatigue and mood. So we managed to do a systematic review here. When we look at the effect size that we can achieve for sleep immediately after treatment, they are huge. Right? They are strong effect size. We have small to moderate effect sizes for pain, fatigue, and depression. We do realize that there are some heterogeneity when we are doing the analysis, so we did a sensitivity analysis to just confirm, to make some sense whether or not we are just looking at the wrong data, but actually we had exactly the same pattern of data, and so that is really encouraging. So Janani Salvanathan in Canada, she subsequently tried to refine the meta-analysis using just patients without malignant pain, so just the non-cancer pain population. And this is what they found, sort of similar to what we had for the sleep outcomes. But for the pain and fatigue, they don't have a fatigue outcome for some reason, but they have pain and depression, but similar outcome, even stronger effect for depression. So lots of evidence is actually suggesting that the use of CBTI in people with comorbid pain is possible. First of all, it is possible. Yeah, we can do CBTI for people with background pain and still improve their sleep. And the second thing is it's encouraging to see that it can be used first to target some other pain-related outcomes like fatigue, like depression. And so that is encouraging. So much so to the point that NICE, which is the National Institute for Health and Care Excellence in the UK, recommended that we should look into using CBTI and CBT-IP, that is the hybrid treatment option, for future research. However, they have recommended it only for research, not for clinical use just yet, because they consider that there wasn't enough evidence. Which is a little bit frustrating. It's a long story that I can fill you in tomorrow if you have time, because there is the gap between, we've got some evidence, but we're not quite there for actually rolling it out for clinical services. So that means that we still need to have more funding, more encouragement for the health services to make it available, make it accessible. And actually, you know what? Just before coming to this seminar, I got an email from Colin Espy. I don't know if you know Colin Espy. He's like the leading expert in Oxford, trying to roll out CBTI digitally through the program Sleepio to the UK. It is already available in some areas of UK for free through the NHS, but he's trying to get a lot of signature to go to the director of the NHS to say that we need to make it even more available, more accessible for people, because of all these funding issues in the UK. So that is where we are at. So funding aside, if we can just go with the ideal, what can we do by adding CBTI to our pain treatment? When we call CBTI, it seems to be a unitary concept, but it is not. Like when I just came out from the European Insomnia Network meeting, we were still trying to think, well, how do we clarify to the general public what CBTI is? When you look at different treatment trials, they will have different components. But essentially, we will be talking about psychoeducation. Some trials will have relaxation or mindfulness component to help people to relax, to reduce the physiological arousal. But the key ingredient for a lot of trials is stimulus control and sleep restriction, which involve changing people's sleep schedule and to help them to reassociate the bed and bedroom environment with sleep so that it can be an automatic behavior again. And for us, cognitive behavioral psychologists, we do believe that cognitive component is super important because that is how you get people on board to do a difficult program. And also, when you're tweaking their sleep, you need to make sure that they understand why they have to go through that tough phase of sleep restriction, and to then teach them the skills that they need to not need you when the session stops. And so that is for subsequent maintenance. So that's why you can see quite a lot of variation in effect size. If CBTI is done properly, you can see high level of effect size, up to 2 effect size, if you have done it properly. But when you do it just digitally, let people get on, no further instruction, no tailoring, your effect size could be as low as 0.3 or 5. So that's why there is the variation depending on how you deliver it. It's more than sleep hygiene, as you probably know, but sleep hygiene is still the sort of like main offering if you go to see the GP, because it's easy. It doesn't really take any tailoring, doesn't really need anything, but psychologically it's all wrong because it's not the way to induce behavior change. But you have to work against the mainstream media to make sure that they are not just sticking with sleep hygiene. The problem is people will come into your trial if you're offering it in the secondary care. They will say, well, I've tried sleep hygiene, it doesn't work. So what we need to try and avoid is that people come across sleep hygiene, come across some low quality CBTI and say, well, it doesn't really work for me. And then they lose faith in what actually could work for them. In a recent dismantling study by Furukawa, published in JAMA Psychiatry, they looked at the different components of CBTI, and they've managed to identify some components being more useful than others. And interestingly, not just some components being not so beneficial, like sleep hygiene or automated engagement, like some of the digital program, they just sort of like keep sending you a reminder, and to the point that you find them very bothersome. Yeah, so they are the components that are considered to be not so beneficial, but there were also some components that they consider to be potentially harmful, like waiting for treatment trial. So potentially that is an ethical point, and some of the relaxation strategy if they are not used properly. So interesting thoughts that we should have in our design or modification of treatment. So finally, just want to say some of the implementation challenges, because when you go to pain conferences, they do, have sleep symposium, they do talk about the importance of sleep, and it seems to be really popular. And even it make it to the multidisciplinary pain management guidelines of the IAPS, and also the pain management guidelines in the BPS. So some of the research that we have done, our group has done, was cited and say, well, they recognize the importance. Pain management programs should have sleep management. However, the reality is that, how do they do that? Because for normal pain management program, it's already really, really long, right? Where do you find that gap to squeeze it in? And if you do have a gap, when would be the best time to do so that you get the maximum effect? I'm just using Christina McRae's spin trial to serve as an example. Like, if you just look at the components for CBT for pain, there are already like multiple sessions for different things like pain education, breathing exercise, activity and rest cycle, visual imagery, cognitive therapy, relapse management. And for patients themselves going through the system, they would also have physiotherapy, occupational therapy, medication management, communication skills training, social care, and employment support. So for them, it's a huge burden. How do you prioritize sleep is a key question. One thing that I've been thinking a lot about and I've been trying to do is perhaps to combine them in such an effective way that you only pick the potent component and combine them with something that is useful rather than the peripheral, and to see if you can streamline it. And that is what I call the hybrid intervention. So on the right here, you can see the sort of CBTI component. So you can actually see that there's quite a lot of overlap between the two packages. So if we have therapists with the right knowledge, with the right protocol, then they can actually chuck out some of the things that are overlapping and do it in a more efficient manner. So in our own hybrid CBT trial, we've managed to do it in 4 to 6 sessions by selecting the relevant components so that we are not spending time on stuff that potentially are not helpful and potentially harmful. So that's the idea of the hybrid CBT, knowing that there are room for streamlining the treatment delivery. But the problem is we need to have therapists who are knowledgeable of both areas so that they can do it with efficiency. So the other thing about doing the hybrid CBT, I think, is that there is the possibility that some of the components of CBTI could cause possible side effects for our participants, particularly sleep restriction. You may remember that I mentioned some of the experimental study where the introduction of sleep fragmentation or sleep restriction could cause pain flare-up or some of the inflammatory marker to go up. And this is exactly the case for a lot of the patients. They will tell you that, well, it has all been going well if you do treatment evaluation. But then if I follow the sleep restriction, it's really, really hard because the pain will flare up and then you are struggling. And so more support is needed. So that rings a bell that you need to tailor CBTI for the pain population. You can't just throw them a automated program and say, do it, and then that is your sleep management. So you need to tailor it so that people are still on board and they get the benefits of better sleep. So at this point, if I can bring back Anne again, she will tell you how she would do the tailoring for herself. Because if you don't do it, your patient will do it themselves. So let's have a listen of what she has to say.
What it is that if you read all of the stuff in sleep hygiene, they talk about only go to your bedroom when you want to go to sleep. In an ideal world, that would be perfect. But I think a lot of us don't live in houses where necessarily that's big enough to do, or we have other responsibilities or for other reasons. I know several people where their bedroom is their sanctuary during the day, away from the hubbub. So what I have learned to do is compartmentalize my brain so that I do go to bed quite early. But when I go to bed, to my bed, which is to really rest my back and my legs, that to me is no different than resting, say, on the sofa or something like that, except it's just much more comfortable. But the minute I turn the devices off, that is bedtime. And what I do is I make the break by going to the bathroom. So I actually leave the bedroom, go to the bathroom, and then when I come back in, that's the bedtime.
Right.
So, and that to me seems much more practical for us to try and do, because staying up till 2 o'clock in the morning really for me wasn't an option, because my partner has quite a serious mental health illness and he has night terrors and night hallucinations, and so him being up in bed without me would have been not a good idea, and he would have found that really challenging. So I had to adapt what I was told about don't go to your bed till 2 with what was practical in my life. And I do hope that people working with those that need this actually look at what's practical in their life.
Yeah, so she spoke really eloquently what she wants from treatment. And so this is the practical issue. Do I have a bedroom that I can practice sleep restriction therapy, that I can follow the stimulus control rules? So that is one practicality that she has been talking about. And sleep partner, never really mentioned in CBTI manual, isn't it? So these are the practical questions that we still need to address. And also staying up until 2 when they have a lot of pain. What do you recommend them to do to deal with the fatigue and the pain flare-up? And so that is something that we need to think about. I don't really have a lot of time left, but I just want to point you to the directions that this is something I think ongoing discussion with clinicians would be really, really helpful to find out what would be the best way to to optimize, to modify CBTI for use. But in the European Academy for CBTI textbook that was published just last year, I've started a process by saying that, well, there are some easy steps that we can try and adapt CBTI for use in pain setting. And that could involve, the cognitive component, where you set the expectation, you guide people through what to expect for the different components so that they have an understanding. It's psychoeducation rather than sleep hygiene, because the feedback that we get from patients, what they really enjoy is to understand the science, how sleep works, rather than being told to follow certain rules. So when they are guarded with the understanding of sleep science, that would help them to practice CBTI better. We also need the tools for people to look at sleep and pain and the interaction together. What about, just adding an item in the standard CBT sleep diary? What about a pain item? What about a fatigue item? So simple stuff that clinicians in their own clinic can try and do to make life easier and to make it possible to start looking into the sleep-pain interaction. And so we have been doing quite a lot of other work to see if we can do the hybrid CBTI in different settings, and so we are still working on it. And with Thomas with us during the postdoctoral training here, we have also been looking into the different approach of doing CBTI by using sleep stabilization rather than sleep restriction to see if that helps with people's adherence. And again, for sleep education, we were thinking, well, maybe they need to have more input on the pain neuromatrix and the relationship between pain and sleep that we just talked about. And so together with Yo and Thomas, we are checking it out and in a feasibility study. So that is it for my talk. Just to summarize everything, it is an exciting opportunity to examine the sleep and pain association, but currently we don't really have a clear pathway. CBTI is potentially effective, but it does need a lot of careful attention in terms of adapting it. And ultimately, if we want to roll it out in clinical setting, we need to have an infrastructure to house it. Should it be with physiotherapy? Should it be with pain management program? Should it be sitting in primary care? Or should it be digital? So lots of questions that we still need to answer. Just want to finish my talk by thanking all the collaborators. They are not all, but I just put the main ones here. But it's a joint effort, and I think it is still ongoing, and we will welcome more questions, more collaboration in the future.
Thank you very much for Nicole's presentation. It's very, how to say that, insightful and thought-provoking presentation. Now we have some time for the questions from the audience, both in person and online. For those joining us online, please feel free to type your question on the chat, and then I will read them aloud. So maybe let's start from the person here, then we can give some time for the online person to type in their questions.
Yes.
I have a question on measuring sleep, and so I'm doing research in children who have cancer or who have cancer, and I know polysomnography is seen as the gold standard in sleep, but I very much struggle with this because if I would use that in a study, I will not get any participants because
Yeah.
we have been through a lot and that is just too much. What would you recommend to do in terms of measurements, but still have some kind of objective measures on sleep, or just
Right, okay. So I guess that's a great question. Should I repeat that for just people online? So the question is about sleep measurement. What do you use for sleep measurements for the pediatric population in the cancer setting? Is that right? Yep. I would say depending on the purpose, because for objective reading, if you have an accurate diagnosis of insomnia, you probably don't need to have objective measurements in a clinical situation, because insomnia doesn't require objective measurements to get the diagnosis. Quite a lot of the work for insomnia is based on people's perception of their own sleep parameters and also their satisfaction of their sleep. So you can still do that to a certain extent in a clinical setting without having to worry about objective measurement, because it's actually a burden for the little kids, like to wear something to monitor the sleep overnight. If you are doing it for research purposes, that is harder, because PSG is notoriously intrusive, although there are some newer version of it that would be quite easy. If you use a sleep cap, that would take away the sort of like hooking up procedure burden from the participants, and that might be easier to do so. But, you know, with a lot of consumer grade measurements like Fitbit, if you wear it on the ankle, that might be easier for kids, and you can have sleep matches to give you some objective measurements. Although I would have to say that the quality of those measurements depends on how you use it. Even for research-grade actigraphy, you have to have a very careful procedure in order to generate meaningful data. Like, when do you ask them to press the button so that you can have the anchor to calculate the sleep onset latency if you wish to have that measurement. So I would say there are some ambulatory monitoring devices that you can use, although whether or not they will give you meaningful measurements is a different issue, because for a lot of clinical trials, when they have a significant improvement in self-reported sleep parameters, they don't necessarily get improvement in the sort of objectively measured parameter. By saying that, it doesn't mean that it is the objective measurements being more important, because I think insomnia is a multidimensional issue. You need to attack both in order to get the best outcome. But so far, we have been more successful in terms of changing the way how people see their sleep, and to help them to be more satisfied, to be healthier with their sleep. And I think that is a very good starting point. And who knows, maybe it just takes some time, you know, for a few more years of practice of good sleep, then they can have a different set of objective parameters to return. But so far, we don't really see a lot of significant objective changes following our CT. So I wouldn't worry too much if you're just thinking about clinical activity. If you want to do it for research purposes, sleep cap to go with PSG might be the way to go.
Just a follow-up question. Do you have any experience with measuring sleep with Fitbits yourself, or anyone of your team? Because I will use a Fitbit in a study now to measure sleep in children who had cancer. And I was just wondering if you can bring me in contact with anyone for a bit of advice to make sure that I get the right data out of it.
Yeah, so we use the Keman Tech motion watch aid. We don't use Fitbit for it because I don't know how they do their algorithms.
Okay.
So I think it's the problem with them being a product, they wouldn't let me download the data raw, and I can't really do the analysis. So I don't really have a contact with Fitbit. But if you are interested in a research grade instrument, I can recommend you a few. Yeah.
Okay. Okay, thank you.
Thank you, Nicole, for an inspiring lecture, very clear lecture it was too. I'm wondering whether you have any preferences or limitations in terms of the type of healthcare practitioner, clinician, what kind of healthcare practitioner you feel has the required skills to actually provide CBTI to patients in general?
Yeah, so this is another big debate in the insomnia network just a couple of weeks ago. Like, should it be delivered by GP or should it be delivered by psychiatrists? How much training do they need in order to do that? So I can't really speak for other people's experience, but in my experience running trials, I've been trying to recruit health psychologists to do that. But the challenge is, in the UK, the sort of training program of health psychologists is not that highly regulated, like the clinical psychologist. And so some of them will turn up with a ton of research experience, but no clinical skills. And some of them could have clinical skills, but doesn't really know anything about insomnia. So it's very varied in one of the trials that I've been trying to do. But in another trial that is not in the pain context, just to train people up to do CBTI in a workplace setting. In that particular study, we did a trial for 6-week online plus 4 sessions over Teams to offer to employees. We've got effect size like 2 for that particular trial for insomnia symptoms. And also improvement in anxiety and depression, significant improvement like 0.8 to 1 point something. So they are just academic psychologists with some background in general psychopathology, but they can be trained up to do so. So I did a therapist training, but I think what is really essential is to have ongoing supervision, so that they bring the cases back to you and then you discuss and train them how to handle the different cases. I think that is where most of the learning comes from, is to do it with some understanding of what's going on. It's hard work, but I think it's doable with some understanding. But you're right, it's actually hard to find the right people to do the hybrid intervention. So that's why I highlighted it as one of the challenges.
Thank you.
Hi, Nicole. Thank you for a wonderful presentation. I was just wondering what your thought would be about the interaction, impact, or link with physical activity, because to go on the previous question, our main goal as a physiotherapist is also to get our patient able to be more able to reach their goal, but also physical activity is a big part of the lifestyle lifestyle changes that we try to incorporate. So where do you see that within the CBTI part, or rather addition to it in the population of chronic pain and insomnia?
That's a great question. I think it should be front and center, to be honest, because I don't see insomnia as a nighttime problem. I always advocate that it is a 24-hour problem. When you target insomnia as a treatment intervention, you should be thinking about changing the lifestyle of your participant. It's not just about the sleep habit or sleep pattern. If you want to get very good outcome, it's all about changing the whole lifestyle in some way. So that's why you need that cognitive therapy to get them on board, to expect what is involved in a CBTI setting. At this point, I wish I have got my own laptop plug-in, because I've got 2 graphs that would directly answer your questions. In one of our previous studies, we just asked people to wear their actigraphy for a week. They are chronic pain patients. We didn't really offer them any treatment. And then we sort of plot the physical activity throughout the day. And then what we found is that compared to days when they haven't been sleeping particularly well the night before, compared to days after they have been sleeping quite well. So this is a within-person comparison. Yeah. The next day's physical activity is different between the 2 conditions of the same person. So we see different circadian rhythm with a a slightly earlier morning push. So you started to see difference in the nighttime with more restless sleep in terms of physical activity. And then you see a morning push earlier for those people with insomnia, not with insomnia, who didn't sleep as well the night before. And then they crash earlier in the evening. And then you can see a bigger dip in the afternoon as well too. So you actually see within the same person, after you have had a good night of sleep or not having a good night of sleep, what would be the difference? And so we published that paper thinking that, well, you know, if you're sleeping better, you will do more. So that is quite a nice message, right? So you can do more. But the pitfall is that you have to watch out, how do you use that extra burst of energy? How do you regulate your feeling well after you have had a good night of sleep? Because if you do too much during that day, then it could actually aggravate the whole thing. So it's that crash and burn pattern once again. And, you know, so it's the interaction that we need to look into further, how they interact with different things. We've got another study by one of my PhD students where we looked at people with and without clinical level of insomnia. Again, plotting out the 24 hours physical activity, different. We saw, you know, significant differences in terms of their physical activity pattern during the day. So we will have to see, you know, what is causing what, because we can't really say, you know, there is a causal association. But by the look of it, it is very integral to what we need to do. And treating people's sleep doesn't mean that we only restrict to changing what they do during the night, because there isn't really a lot that we need to do. But you also need to make sure that they're exposing themselves to sunlight so that they're resetting the circadian rhythm. They're doing enough physical activity, and that could activate the mood. And that is the reason for the hybrid intervention. We have behavioral activation during the day. And so that is about selecting the right ingredient for our population. Yeah, physical activity is front and center.
I think the online audience are too shy to give them questions. So, well, I believe we have come to the end of this Pain Emotion Masterclass. And thank you once again for your insights, time, and sharing your knowledge to us. And also a big thank you all for all people participating in this Pain Emotion Masterclass. We hope you enjoyed the session and also learned some new perspectives that can use involved in your own work. So wishing you all great, and especially to the online participants. So he can wish all participants a great rest of the day, and we look forward to welcoming you for the next Pain Emotion Masterclass. Thank you. Yeah.